today for our second series of the billing and coding. Today we're lucky to have Lisa here, I'm saying that right, here, talk about outpatient billing, and I will let her start.
All right. Hi, guys. My name's Lisa Hare. I'm one of the compliance managers here at MUSC Physicians. I personally handle the departments of OBGYN, Carolina Family Care, Family Medicine, and Diagnostic Radiology, as well as the College of Nursing. Today, we're going to talk about outpatient coding and billing. Okay, so just a little bit of housekeeping for the continuing education for the nursing. We have this information here that tells you what you're going to need to do to get your education credits. The Muhan Nursing Professionals, sorry, I didn't read through this slide first.
It will come through MyQuest once
Okay.
you complete the certificate. And just we're just making sure that you know that there's no conflict of interest.
Got it. Okay. Next, here's our dates for the rest of this series. It shows that we completed the general coding and billing on January 8th. Today we're doing outpatient coding and billing, and then our upcoming sessions for the months of March, April, May, and June, and what will be discussed at those sessions. So again, to get your credit for this, you need to make sure that you sign up through MyQuest. You can view this live or through WebEx. None of our presenters have any disclosures. You'll obtain your CEUs or CME credit. The APRNs are going to receive that certificate through MyQuest. Physicians and PAs will get their certificates by the MUSC CME office. So our objectives for today, we're going to describe the differences between a new patient, an established patient, and consults as defined by CPT. I want to make sure that you can recognize examples of documentation to identify the history exam and medical decision making, and indicate the correct level of service for new, established, and consultations based on your documentation. What I'm not going to talk about today are specific levels of service other than outpatient codes. I'm not going to go over ER codes, observation codes, preventive services, or any other CPT codes that fall outside of the evaluation and management category. I'm not going to talk about EPIC issues, APP guidelines, specialty-specific documentation, or workflows. We just don't have time to get into that much detail. All right. So just a reminder from the last session, all of your E&M codes require 3 key components: history, examination, and medical decision making. Keeping in mind that medical necessity always needs to be the overarching factor in any services that we bill. So first, let's talk about what outpatient means. An outpatient service is a service that is provided to a patient in an office or an outpatient or ambulatory facility. A patient's considered to be an outpatient until admission to an inpatient facility occurs. The 3 categories of evaluation and management services that we're going to focus on today are new patients, established patients, and consults. You'll notice that I included on this slide what is required as far as the 3 key components for the levels of service for each of those codes. The difference is established patients only require that 2 of those 3 key components be met. Your new patients and your consultations both require that all 3 of those services meet or exceed, or excuse me, the key components meet or exceed the level of service that you're choosing. So you should remember this from the last session. This is our evaluation and management audit tool. So just to recap, the history that you need to document in all three areas to establish your level of history, so your HPI, your review of systems, and your past history, family history, and social history. Exam's pretty self-explanatory. You either have a problem-focused, an expanded problem-focused, a detailed, or a comprehensive. Medical decision-making is 2 out of 3. So 2 of the 3 areas of medical decision-making are needed to determine your level of medical decision-making. So that's broken down by your diagnosis management options, your data reviewed, and your risk. So let's talk for a minute about what constitutes a new patient versus an established patient. An established patient is one who has received, an established patient is one who's received a professional service from a physician or qualified healthcare professional or another physician or qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years. If the reason that you're seeing this patient is strictly for coverage purposes, you treat that patient as an established patient, even though technically they may be new. When advanced practice nurses and PAs are working with physicians that are considered as working in the exact same specialty and exact same subspecialty as that physician. So if they've seen the physician in that practice, even though they might be new to you, they're going to be established. These are the new patient evaluation and management codes, 99201 through 99205. I listed out the minimum requirements for each of these codes. So for your 99201, you must have a problem-focused history, a problem-focused exam, and straightforward medical decision-making at a minimum. 99202 requires expanded problem-focused history, expanded problem-focused exam, and straightforward medical decision-making. 203 is a detailed history, a detailed exam, and low complexity medical decision-making. 204 is comprehensive history, comprehensive exam, and moderate complexity medical decision-making. And 99205 is comprehensive history, comprehensive exam, and high complexity medical decision-making. And I see people writing notes. We do have little laminated pocket tools that has this information on it. If you don't have one of those and would like one, get in touch with your compliance manager. We can get those for you. Next are the established patient codes. Those codes are 99211 through 99215. Again, I listed the minimum required documentation. Remember, these only require that 2 of the 3 requirements meet or exceed. 99211 typically is considered a nurse visit. It doesn't require the presence of a physician or any other qualified healthcare professional. 99212 is a problem-focused history, problem-focused exam, and straightforward decision-making. 213 is expanded problem-focused, and low. 214 is a detailed history, a detailed exam, and moderate complexity medical decision-making. And your 215 is a comprehensive history, a comprehensive exam, and high complexity medical decision-making. Again, especially when you're looking at your 99215s, keep that medical necessity in the back of your mind. Next, we're going to talk a little bit about consults. The first thing I want to emphasize is the definition of a consult. A consultation is a type of evaluation and management service provided at the request of another physician or appropriate source to either recommend care for a specific condition or problem, or to determine whether to accept the responsibility for the ongoing management of the patient's entire care or for the care of a specific condition or problem. Your documentation has to contain your 3 R's. That's your request. So who asked you to see that patient and for what? Render. You need to render your opinion either in the form of a letter or your detailed progress note that can be sent out to that requesting provider. And then your report back. Either CC the note back to the requesting requesting provider, or make sure that you send a letter back to them. For outpatient consultation codes, again, here's your 5 codes. They are 99241 through 99245. As far as what's required documentation-wise for these, the requirements are exactly the same as for a new patient. So all 3 so for 99241, problem-focused history, problem-focused exam, straightforward decision-making, etc. So the next thing that I want to do is walk through some examples. So here we have a note. Uh-oh. It's not going to let me annotate it. Okay, well, I had this really good plan to highlight these in real time, but with it in presentation mode, it's not going to let me do it. So, look. Can we? Okay. Okay. Is it going to? There we go. Sorry, guys, technical difficulties. There we go. Okay. Make it bigger. Okay. So in this example, this was a new patient coming in to establish care. A 24-year-old female who was presenting as a new patient for evaluation of establishing care for swollen tonsils for 3 weeks. So the way that we're going to figure out our level of service for this new patient is we have our location. So it was the patient's tonsils that are bothering her. We have the duration of the problem, approximately 3 weeks. Also, I didn't mention, keep in mind, we always have to have a chief complaint. If we don't have a chief complaint, we essentially don't have a note. So in this case, the swelling in the patient's tonsils is going to be our chief complaint. Tonsils are our location. Approximately 3 weeks is our duration. This patient had associated signs and symptoms. She talks about that she also has a headache, increased fatigue, and pain when swallowing. When swallowing could also be timing. And she has taken a prescription of Augmentin for tonsillitis through the course of this. So we have at least 4 HPI elements right here. We We could possibly find more out of this, but we don't need to. 4 is the maximum that we need. So there's our HPI. Next, we have our review of systems. Here she talks about she's denying neck pain, fever, stiff neck, ear pain, diarrhea, myalgia, and shortness of breath. So we've got musculoskeletal, constitutional, ear, nose, and throat, GI, and respiratory for our review of systems. We have a past medical history for this patient. We have a social history for the patient. Turn this off. This was a really good plan in my head. We've got medications, we've got allergies. Did I say we had a social history? Yes. Okay. So that means we had all of our past history, family history, and social history, all 3 of them. Then we have this statement for review of systems. It says that 11 systems were reviewed on the new patient intake form with no changes other than noted in the HPI. Does anybody see a problem with this statement? The problem with this statement is the fact that it says that there are specifically 11 systems reviewed. If you're going to specifically say that you looked at a certain number of systems, you need to actually name them. Otherwise, this would be an absolutely fine statement and perfectly acceptable if all it had said was the remainder of a complete review of systems was reviewed and negative. That is absolutely fine, but this statement as it stands right here is not acceptable. So the review of systems that we actually get to count are those ones that were in the HPI that I named off. And that's it. So we did not get to 9 review of systems on this patient, or excuse me, we didn't get to 10. We had between 2 and 9, which puts us at a detailed review of systems. We have a complete physical exam on this patient. And then we get to our assessment and plan. We've got a new problem that they did some additional workup for. They ordered labs for this patient. And ultimately what it comes down to is that she had an undiagnosed new problem, which is moderate complexity. So this is what it looks like when you look at it on an audit tool. I'm going to put this back in presentation mode for a minute. Oh, really? I didn't see that. Okay. So this is what it looks like on the audit tool. We had our chief complaint, swollen tonsils. We had our location, duration, modifying factors, and signs and symptoms. Our review of systems were our constitutional, ears, nose, and throat, respiratory, GI, and musculoskeletal. Past history, family history, and social history. Comprehensive exam. We had a new problem with additional workups, so that was our 4 points that we needed for the diagnosis management options. We had 1 point under the data review, and an undiagnosed new problem on our table of risk. So, anybody want to take a guess at what level of service this is? 3. It's actually a 4. This was a new patient. Oh, I'm sorry. I'm wrong. It was a 3. We had a detailed history. Because this was a new patient and we only had a detailed history, 99203 is the best we can do. However, if that review of systems statement had just said all others were reviewed in negative, that's all it would have taken to make this 3 a 4. Okay. So this is our next example. And in this one, we have an established patient who comes in for nasal and chest congestion, cough, and chest discomfort for 3 days. There's my note. So we had our chief complaint. They have the concerns of the nasal and chest congestion. We have an associate sign and symptom in the cough. We've got chest for location. Duration again is 3 days. And we've got modifying factors because she's tried taking some Mucinex. Our review of systems, we have a general, a cardiovascular, pulmonary, ENT, GI, musculoskeletal, neuro, skin, psych, and endocrine, which the endocrine is not listed there. I pulled that from up in the HPI where she talks about no diaphoresis. We had a past medical history. There's medications. We have family history, past surgical history, and social history. We got plenty of vitals. Then we have our physical exam. And again, we've got a full comprehensive physical exam here. And then we have our assessment and plan. So this patient's got a viral upper respiratory infection, costochondritis, and she also talked about that she had some reflux that she had not been taking anything for, that we're prescribing Prilosec for. So for this one, this is what our audit tool looks like. Again, we had plenty of history of present illness. We had a full review of systems because we had 10 review of systems. And we had all 3 past family and social histories. We had a comprehensive exam. We had a new problem to the examiner with no additional workup. We didn't have anything in the data reviewed or ordered section. And then we had moderate complexity on the table of risk. So if you look at this, because this is an established patient, technically, when you look at the numbers, you think this is a 99215. However, this is where your medical necessity comes into play. There is no way that this is ever going to be a 99215 based on what the patient came in for. So we're going to drop this back to the 99214 that the medical decision making supports. Anybody want to take a guess? Now the reason this was a 4 was because she had the acute upper respiratory infection and the GERD along with it, because you've got that chronic condition that's mildly exacerbated. The GERD's actually what got it to a 4. If she hadn't had that, and this was just the upper respiratory infection, where are we at? Exactly, the 99213 in that case.
So Lisa, can I test out some skills?
Sure.
So for the 5, in my mind, it's like if that patient is admitted to ER and have very good documentation to suggest via EKG or chest X-ray or something like that, that they're on their way. So that
Right.
to me is a 5. Is there anything else that I'm not thinking about?
She may have had asthma that was being severely exacerbated, and you had to keep them in the office, do breathing treatments, observe them. That'll get you a 5. That kind of thing. All right. Our next note is a consultation. You like my referring physician? It was the first name that came to mind. So in this case, this person came in for an eardrum rupture. So we've got our chief complaint. We've got our location. So here's our location here. We have context in this case because he says that he was hit on the left side of his head about a year ago, a year and a half ago. The year and a half ago is duration because this has been going on for that long. And we've got associated signs and symptoms because he's now developed ringing in his ears and decreased hearing in his left ear. So there's our 4 HPI elements. Our review of systems. Here we have dizziness, so that's neuro. Ear pain, that's ear, nose, and throat. Ear drainage, that's still ENT. Still ENT here. Denies worsening hearing, notes tinnitus. So essentially, we have 2 review of systems here. We had neuro and we had ear, nose, and throat. We've got past medical history, past surgical history, social history. Family history was reviewed. There was no pertinent family history. So we get to give them credit for that. And then we have that lovely review of system statement again. So again, that leaves us with 2 review of systems for this note. We have a full exam and our assessment and plan. And in this case, again, we had a new problem. We did some additional workup. They ordered an audiogram, which falls under the medicine section of the CPT book, so that's a medicine test. And, oops, they also said that they're going to contact the referral office to obtain records. So we also get to give them credit for the decision to obtain records. And our risk is we had a chronic illness that has mild exacerbation or progression. So here's how it comes out on the audit tool. Chief complaint, eardrum rupture, 4 HPI, our 2 review of systems, all 3 past history, family history, and social history. So our overall history is going to be detailed because we got to drop down to whatever that review of systems was. We've got our full 8 system comprehensive exam. Our new problem with additional workup gives us 4 points for the diagnosis or management options. The data reviewed, we get 1 point for the decision to obtain records and 1 point for ordering a medicine test. And then our moderate complexity on the table of risk. So our risk, or excuse me, our medical decision making for this patient comes out to moderate because that section of the audit tool is 2 out of 3. So what's our code going to be for our consult here? It's a 99243. Again, the only reason this is a 99243 is because of that review of system statement. So just fixing that one little statement changes this from a 3 to a 4.
Well, when you look at the review systems, it really only has a 2.
But if they had said that all others were reviewed in negative, instead of saying that 11 were reviewed, that's what it would have taken. Yep.
So when you say 3 out of 3 components for new patients and consultations versus an established patient needs 2 out of 3 components, are you speaking to the review systems?
I'm speaking to the history, the exam, and the medical decision making.
Then you said 2 out of 3 components of that as well.
Right,
Okay.
because history is made up of 3 parts: HPI, review of systems, and past history, family history, and social history. And medical decision making also is 3 parts: the diagnosis management options, the data reviewed, and the table of risk. So on the history portion, it's 3 out of 3. So if you fall short in any one of the 3 categories, you're going to drop your level of history down to whatever your lowest one was. In the medical decision making, it's 2 out of 3. So here we had high complexity diagnosis management options, but low complexity data review and moderate risk. So we're going to split the difference and go with the moderate. So for this one, what would this have been if it was an established patient with this exact same documentation? Actually, it's a 4. And I can see, I'll show you right here. You need 2 out of the 3. And we have enough complexity. So here is where we score the established patient. I know that's small. But here's where your detail comes out. Here's your comprehensive for your exam. Because that's a picture, it doesn't want me to highlight it. Anyway, it's detailed, comprehensive, and moderate. So that equals out to a 99214. So then, just backing up, this was our established patient. Where would we put this if it had been a new patient? Yes, it would still have been a 4 because there was more than enough documentation here for that level 4 established patient. This was the established patient. This one had a good review of systems. Yeah. So because we still had a comprehensive history and a comprehensive exam on this one, we had, like I said, we had more than enough. Technically, this would have been a 5, except that it wasn't, the complexity wasn't there for it. So we made it a 4. So if this had been a new patient, we still would have been a 4 because we still had a comprehensive history, a comprehensive exam, and moderate complexity. That make sense? You with me?
I was reading.
Okay. All right. So those were the examples that I brought, that I had to go over with you. What questions do you all have with regards to E&M coding still? Because we still have plenty of time.
Talk about like post-ops and when the global periods are for different payers, and then when things might change, whether they present with different system that you can offer establishments.
Yeah, let's cover that in its own session, because that could be a session in and of itself.
So when you look at the card
Yes,
for, say, a return, for example's sake, and you look at the definition of the moderate medical decision-making, which doesn't include the scorecard of the three components. but
Right.
It's kind of an overarching view, like you mentioned. before.
right, that's your medical necessity.
That's where the details get a little. So when I teach this, I kind of look at this and I sort of skip those three components, but I really should not do that because it does make a decision whether it flips up or down.
It does, and especially for your new patients and your consults, you have to have all three of those. So they've got to be there. The medical necessity, even though it has to be there, it's got to be, the components have to be there too. So, but yes, you are absolutely right, especially with your established patients. You've always got to think about that medical necessity and, do they have one stable chronic condition, or do they have two or more stable chronic conditions, or is there an acute problem on that day that is presenting a immediate threat to the patient's life or bodily function, because that's going to make a big difference, because especially when you've got an established patient that looks like it could be a 5, but the components only come out to a 4, you have to think about, okay, how sick is this person really? If this person, like I said, had been in there with a severe asthma exacerbation, now this is an immediate threat to this patient. So even though it might not be a new problem to you, so it may not, the numbers might not add up to that higher level, as long as it's in your note that this is a severe exacerbation and what you had to do to stabilize that patient before you could let them leave your office, we're going to see that, and we're going to understand that, okay, this was an immediate threat to this patient, and we're going to go for that higher level at that point. Yes.
Just since it's on the form, can you comment about the time parts and when that would be beneficial to document?
There actually is going to be a session on that as well, but I will say that when you're talking about an evaluation and management code, if more than 50% of the total visit is spent in counseling and coordination of care of the patient, then you can bill based on time.
Did that go also for outpatient home consults?
No. Right now, these have to be face-to-face encounters with the patient. Things are inching closer to being able to do things via email and over the phone, and that, but we're not there yet. Right.
Are we going over chronic care management at some series?
I don't think it was in the list because it's so specific.
Is it only to primary care? Or can
It's
be
not
specialty?
limited to primary care, but it really is designed to be more of a primary care function, because you really have to be taking over the management of that whole patient. I think there were some new codes that came out this year that kind of do lean more towards the specialists and only managing just a particular problem. Because I think they recognized that specialists were trying to figure out how they could do chronic care. And then when they discovered that it meant that they had to be available 24/7 to these patients for whatever was going on with the patient, they went, oh, wait a minute, we don't want to do that.
So going, I know, no, we're not doing that. Telephone management, there are codes for that. Is it just that we at MLC are not doing it? This is like a 99443, which is telephone eval and management to an established patient.
There are very, very specific criteria that have to be met and documented. And the majority of our payers do not pay for them. So as an organization, up to this point, we've made the decision we were not going to do those. Right. Right. So if that, shifts in the future where payers start to pay for those, then we'll revisit that. But at this particular point in time, we don't. Any other questions?
Any questions?
Any of you on the phone have any questions?
No, I think I'm good.
Okay.
Thank you very much.
Thank you.
Thank you.
Thanks.
Very-
Thanks a lot.
Hoping I had enough to.
That's fine.